Good evening all. My name is Poonam Yadav. I'm working in marketing department of Hetero Healthcare. On behalf of Hetero Healthcare, I would like to welcome you all in this webinar on current recommendation for HIV treatment. Before we proceed with the scientific agenda, I would like to take this opportunity to brief you all about Hetero Healthcare, which is among the largest producer of API across the world and has a strong partner with HIV expert. At Hetero, our every action seeks to inspire human belief in accessibility and affordability of life-saving medicine. We mark more than 25 years of our journey in HIV management and catering to 40% of existing global demand for antiretroviral APIs and finished dosage form. It was possible due to strong R&D team and state-of-art manufacturing facilities that ensured to seamless supply of medicine. It would have not possible without your support and blessing.
Pradeep, you can introduce.
Good evening all. Good evening all. Today we have Dr. Akashneel Bhatacharya with us. He is very eminent speaker on and expert in HIV treatment. And Dr. Akashneel Bhatacharya is DM in infectious disease from AIMS and have 15 years of experience in the medical field. So now Dr. Akashneel Bhatacharya is associated with Paras Hospital, Gurgaon. So with this small introduction, I just want to hand over the session to Dr. Akashneel Bhatacharya. So, hello.
Hello, yes.
Welcome, sir.
You.
Welcome, sir.
Thank you.
You have to just write down the slides, so at least I can open the slides.
Actually, sir, there is a technical issues. I'm not able
Yes,
to move my slide.
Okay, I think
Yes,
I can share my.
Yeah, sir, you can. Please, sir.
Girdhar.
Yeah.
Can we start one minute?
Yes, Poonam.
Yeah, sir, it is okay, sir. Yeah. We can go with the presentation mode. Yeah.
Okay, should we start?
Yes, sir, we can start.
Okay. Am I clearly audible to all of you?
Yes, sir. Audible.
Okay. So very, very good evening to everyone. So I am Dr. Akashneel Bhatacharya. I will be talking about current recommendations for HIV treatment.
Yes, sir.
So we have different data sets coming from different societies all over the world. So our prime target is to find out the individuals who are having HIV. So as per WHO targets that 90% of the individuals who are having HIV should be aware of their HIV status. The importance lies in this word is that there are many patients in our society who are roaming around, but they are unfortunately unaware of their HIV status. There is no guideline for routine testing of HIV in our country, but it is the awareness of an individual, being clinicians, being the specialist in this field. This is my work as well as the work of the other specialties also, that to aware people that you should get yourself tested. Without the test result, no one can identify the patients. So our target is 90% of the patients should be aware of their HIV status, which was achieved in the world stage. It is 84% is achieved. And among those HIV positive patients, 90% of them should be on HIV treatment, which was achieved. That figure is 73%. And among the patients who are on HIV treatment, 90% of them should be virally suppressed. So what does it mean by viral suppression? That whenever you test yourself for some an HIV patient, when he gets tested for viral load, so as per our guideline, our government NACO guideline, the number of the virus, we call it copies, it should be below 1,000. So if you go by the Western guideline, so the number is more stricter, it is 200. But with the advent of very good antiretroviral agents, it is very welcoming. These agents are very welcoming to our clinical practice. Even we can see that patients are leading their lives for more than 5-6 years with the same medication, with a complete viral suppression. Most of the patients who are very compliant with the medications. So this is from the public health point of view, this slide is designed that our target will be to diagnose more and more patients who are having HIV and put them on treatment, and they should be on proper treatment to get a viral suppressed state. So in India, unfortunately, these figures are very much low. There are only 74% of these are statistical estimations. No one can say these are the absolute figures. So in India, the numbers are very low, that you can see that only 74% of us, we are aware that we are having that infection. And among them, 65%, they are on HIV treatment. So we have lost 35% of patients who knows that who know that they are having HIV, but they are not on treatment for some reason. And among those who are on treatment, only 61% is virally suppressed. So it is the duty of all of us, not only the clinicians, it should be a coordinated effort from the public health point of view for more testing, more compliance, more good quality supply of medications, and also the proper follow-up system. So in recent years, UNAIDS, they have come up with a very good approach, that they are saying that this is not only the testing and the follow-up and everything. So it should be a coordinated social, political, and health approach to decrease the number of patients who are not on ART, increased case finding. So they have set up a high benchmark of 95%. As you can see over this figure, that is a chain. So the chain starts from your right, that 90% of people living with HIV and AIDS, they're at risk. They are linked to the people-centered and context-specific integrated services. So 90% of the individuals who are having this virus in their body, they should be channelized to this chain. So through this chain of events, so we will ensure that 95% benchmark of treatment. So the outcome will be, it will be a definitely a better outcome, that less than 10% of countries will have uh, um, punitive laws and policies. Now you can see this is not a medical disease. This is a social situation, social stigma from which we have to come out. We have to take those persons out from this social issue. That many countries, they have punitive laws and policies, like punitive meaning that there might be some punishing laws. If someone is getting tested for HIV, so they should be terminated from their jobs. In India, we have very good governance regarding this HIV and AIDS patients. They are legally protected from their job loss. Can they have their right not to reveal their sero status to anyone. So now coming to the testing of HIV. Everyone asks me that what is the window period? Even among the doctors, many of us, they are not very clear about this window period, as this window period varies. So what is the window period? See, someone is getting that virus inside their body, inside their bloodstream on day 0. So when the test will give you a positive result, or how long you have to wait for the result to come positive to know that person is infected or not. So the window period varies with the testing method you are using. So if you are using PCR, which is called nucleic acid test or nucleic acid amplification tests, the window period is lower. It might be as low as 10 days. So if you are going for the serological tests, so the window period is gradually increasing, you can see. So nowadays we are having fourth generation ELISA, which combines P24 antigen to it, so that the window period is decreased to, you can say, around, it is around 3 weeks you can detect. Even some kits, some companies, they are saying that the window period is as low as 2 weeks when you are using this um, serological test, ELISA, CLIA, CMIA based test combining P24 antigen. So it is the standard of testing is always a fourth generation ELISA in nowadays. So this is a very nice and table which shows how can you remember, or how can you have a visual idea about the tests you are using in terms of the window period. So you can see that NAT, nucleic acid amplification test. So it is a day of infection, the days post-infection 10. On the 10th day, NAT can give you a positive result. On 2 weeks, fourth generation ELISA. So we do not perform usually this third generation, second generation, first generation. So if you want to detect it very early, you can go for PCR, or else you can wait for the for 2 weeks to get the fourth generation ELISA done. Testing is very easy and it is not very costly, but we have to convince more and more people to get themselves tested. So this is this table shows that the graph is showing. So you can see the first one, the bold one, it is the HIV RNA, and this day 0 is the day 0 of infection. And after 10 days, you can see that when the virus replicates inside our blood, so HIV RNA, it is going very high and very steep. So at around 10-14 days, you can detect this HIV RNA easily from PCR. After 14 days, you can see that this dotted line, this is showing that HIV-1 P24 antigen. This P24 antigen has now been incorporated in the standard ELISA technique of HIV detection. where we can identify this infection very early, around what I mentioned, at around 2 weeks of time. So the window, when the window starts from day 0 and the window ends at, you can say, day 22-24, when HIV antibody comes. So you know that whatever you can go for, even we call it early infant diagnosis. So the infants who are born from HIV positive mothers, then in that case also we first go for the PCR testing NAT to identify whether it has been transmitted from the mother to the baby or not. But despite having 2-3 NAT tests positive, we still do not label those infants as having HIV confirmed HIV. We call it HIV NAT positive, as HIV is always a serological diagnosis, that is antibody based diagnosis. So if you go by the ELISA, it is also antibody. The confirmatory test, which is Western blot, that is also antibody, right? So this is called the seroconversion window, that when someone is having the infection and someone is mounting the antibody response to the HIV virus. So now, when to start treatment? When do you start your patient? When do you want to start your patient on antiretroviral therapy? So now the strategy we follow since many years, but unfortunately, I still see clinicians, general physicians asking that someone is having high CD4 count, so should I go for treatment or not? So if someone asks me why doctors and paramedics and medical practitioners and everyone is so ignorant about this disease, so it is not their fault. The onus lies to the government bodies, the public health, how they are disseminating the information to the general medical fraternity. So everyone is waiting for the new information to come. No one wants their patient to suffer. Everyone wants to be updated. But it is the lack of communication between the ART centers, NACO, and the private practitioners. That gap has to be bridged. Our government is doing many fantastic projects and very aggressive public health interventions to curb tuberculosis. So this type of efforts is very much expected from our public health system in our country on HIV, and I hope it will come very soon. So it is the test and treat strategy. So current NACO guideline says that all persons diagnosed with HIV infection should be initiated on ART regardless of the CD4 count, or WHO clinical stage, or age group, or population subgroups. So it has clearly mentioned who is having a report of serological test positive of HIV after confirmation, everyone should be started on ART. So how do we initiate ART? So for the very first thing, you have to know that what is OI, that is opportunistic infections. Before initiating someone on antiretroviral therapy, you have to rule out opportunistic infections. And our target to start ART is only 7 days. Whenever someone is tested positive, someone should start ART within 7 days. But by that 7 days time, you have to find out if that patient is having some other underlying infections. There are few infections, life-threatening infections like tuberculosis, cryptococcal meningitis, which has to be identified before starting ART. I'll come to that. So what are the drugs we have to treat HIV? So this looks like a very complicated diagram, but if we see by point to point from number 1, 2, 3, 4, so we'll get to understand that this this is the virus entry. Where the virus is getting entered, it is the human cell. So viruses are always dependent on human cells. So first this virus, it gets entered by the receptor GP120 and also the co-receptor of CCR5, and this is which cell it is? It is the CD4 cell. So this virus replicates predominantly in the CD4 cells. So they specifically damages CD4 cells, so the CD4 count goes low. So it is the entry of the virus, first step. Second is the reverse transcription. As you know, this is a retrovirus. So this is the viral DNA, RNA. So retroviruses have their capability to form DNAs from RNA. So you see that the enzyme comes into place, the reverse transcriptase. The importance is that I will come to the drugs. So it is better, it will better understand it by for better understandability, I incorporate this diagram. Then this viral DNA is integrated into the host genome. This process is called integration. Then after this is integrated in the host genome will transcribe. From the process of transcription, the mRNA will form. It will get translated into proteins, the viral proteins. There will be cleavage of viral proteins. From a bigger protein, smaller proteins will be produced. Everything is happening inside the CD4 cell. And there will be the assembly of those smaller proteins into the viral structures, and newly formed viruses called virions. So they will go out from the cells by protease inhibitors. This is at the by the protease. So these are the uh, viral enzymes. So now if we see the drug classes, so I told you that there is an co-receptor called CCR5. So there is a drug called Maraviroc, which is CCR5 co-receptor antagonist. Then you come to the virus entry. By the fusion of that virus, it enters into the CD4 cell. So you have a good antiretroviral drug or enfuvirtide, which is a fusion inhibitor. Then if you see the reverse transcriptase enzyme that the retroviruses have, you can inhibit these enzymes by NNRTIs, which called non-nucleoside reverse transcriptase inhibitors. So these drugs are the inhibitors of these enzymes, which causes the reverse transcription. Then comes the integration. So now the backbone of the ART regimen we use, it is based on this integrase strand transfer inhibitors like dolutegravir, bictegravir. Then comes the protease enzymes, which causes the cleavage and also causes the also helps the virus virion to release from the infected cell. So protease inhibitors work here. So you have multiple areas where you can design your drugs to inhibit the virus, but unfortunately, due to the continuous mutation of the virus, so we are still not able to, unfortunately, not able to uh, invent any antiretroviral drug which can completely cure the disease. But we have a very good, highly active antiretroviral therapy which, if the patient adheres to, so he or she will be very much fine. I can say that person can lead a normal life. So these are the like textbook classification of the drugs. So everyone, we have come through this at any point of time. The doctors, that nucleoside and nucleotide reverse transcriptase inhibitor, zidovudin. Previously zidovudin was used. So from uh, different dreadful side effects. So it is not in our best of the choices. So now we use uh, three drugs as a standard ART regimen, which are mentioned in the red color. Lamivudine, tenofovir, and dolutegravir. So it is called the TLD regimen. So why so much of drugs that if someone develops some side effect to one drug, or we can detect genotypic resistance to some of the drugs. So we can switch to the other group of drugs. But the standard regimen still lies that TLD, tenofovir, lamivudine, and dolutegravir. D is placed on the last, but this dolutegravir, this integrase strand transfer inhibitors, they are the backbone of today's ART regimen. So what are the goals of ART? You have 5 goals of ART. Clinical goals, virological goals, immunological goals, therapeutic goals, and preventive goals. So what is your clinical goal? Your clinical goal is increased survival and improvement in quality of life. So in the
Girdhar,
I think doctor has left.
Pradeep, just call this, sir.
Okay.
for that issue. So I think this slide was, or when I said something, so it was audible.
Yeah, that is
So
audible, sir.
I am
Even
starting
goals of
from this
ART.
slide.
Yeah, goals of ART.
Oh, thank you for your patience. So we have 5 goals. So the clinical goal is the increased survival and improvement in quality of life. Whenever we prescribe ARTs to our patients, so when they come back, first thing they say that we are feeling very nice after many years, that there is a general well-being, and they are able to do more work. They are more success. They are getting more success in their work field. So it is a very nice feeling from the clinician's point of view also, that we are dealing with such good medications. So what are the virological goals? That the greatest possible sustained reduction in viral load. So we want to have viral suppression, but it should be sustained for very long years. Immunological goal is immune reconstitution, that there is a very rapid fall of CD4 count in the later stage of the disease. So we wish to get a higher level of CD4 cells and the percentage of CD4 cells. So we call it immune reconstitution. And the therapeutic goals are the rational sequencing of the drugs. We have many drugs from many drug categories. So the choice of drugs should be very rational, and keeping in mind first 3 goals: clinical, virological, immunological goals. For the preventive goals, that it prevents the transmission. ART in turn prevents the transmission of HIV from one person to another. So the effect of heart on HIV transmission. So what is the effect of ART in HIV transmission? So UNAIDS, they conducted a campaign all over the world. So 3 large studies of sexual HIV transmission among thousands of couples, one partner of which was living with HIV and other was not. It was undertaken between 2007 to 2016. Long years, 9 years, many individuals. One is having HIV, another person is not having HIV. So there was not a single case of sexual transmission of HIV from a virally suppressed person living with HIV to their HIV negative partner. So you can think about this, that someone is having, one partner is HIV positive, one is not. They are engaging in sexual activity, but if the HIV positive partner is virally suppressed, then there is virtually no chance that he or she will transmit the disease to his or partner. So this campaign became very popular, and it is always shown and reminded as undetectable equal to untransmittable. So primary ART regimen, it is consists of three-drug regimen, three drugs from preferably from three different classes. So the standard first-line regimen, as I told you, that it is tenofovir, lamivudine, and dolutegravir. So dolutegravir, it is the integrase strand transfer inhibitor. It has a high genetic barrier for resistance. The word means that in spite of using dolutegravir for a long time, the virus usually does not develop a genetic resistance to dolutegravir. It is approved by FDA in 2013 for INSTI-based ART regimen, and it is recommended by WHO in 2019. And in July 2020, NACO has recommended this drug, and we have ample supply of dolutegravir in the government setup. So the most preferred drug for both first line and second line regimens is dolutegravir nowadays. You have to be cautious for a few things, that if it is a child less than 6 years, you cannot use dolutegravir. Body weight should be more than 20 kg. And rifampicin being a drug inducing agent, so it decreases the level of dolutegravir. So whenever you are treating HIV and TB co-infection, you are giving rifampicin, so you have to give extra 50 milligram dose of dolutegravir. There is a very good study published in Lancet HIV, that dolutegravir based and low dose efavirenz based regimen for the initial treatment of HIV or infection, the NAMCEL trials, the results were very promising. So it is, you can say, TLE. Usually previously we used to use TLE, that is tenofovir, lamivudine, efavirenz versus TLD. So primary endpoint of the study was viral load of less than 50 copies at week 48. So you can understand, so it's very short period of time. So results were found that at 48 weeks, in the dolutegravir group, 74.5% patients, they achieved less than 50 copies of viral suppression. And in the efavirenz arm, it is 69%. So the result was statistically significant. So the third point, which was also statistically significant, that viral load suppression was significantly more rapid in the dolutegravir group. That is the integrase strand transfer inhibitor group compared to the efavirenz group. So weight gain and obesity, these two problems, it was addressed, which was found in the dolutegravir group. So who are on TLE? Till date, we get many patients who are still on TLE, which is not well tolerated among the patients due to the component efavirenz, and also the incidence of virological failure is higher with efavirenz. So if you get a patient who is on TLE, so our approach from the national health point of view, also from the NACO guidelines also, you have to transit those patients from TLE to TLD. So what are the criteria where you should look for? That the baseline evaluation CD4 count should be stable, there should be viral load should be, patient should be virally suppressed. So you can safely make a transition from TLE to TLD. So after transition to TLD, so we monitor for normal blood tests, CBC, LFT, KFT, and CD4 count and plasma viral load for after 6 months. So it is a very good strategy which was adopted by NACO to transit from all the patients who are on TLE to TLD. Now coming to a specific problem and specific situation, that HIV and TB at times it really coexists. So whenever someone is having HIV, you should be very careful to find if that person is having tuberculosis or not. Very crucial and very thorough scan, both clinical, radiological, you have to perform to find out if there is any focus of tuberculosis. So you have to start TB treatment before starting ART. So in other TBs, apart from TB meningitis, you can give 2 weeks of ART, then you can start your. I'm so sorry. So you can give 2 weeks of ATT, that is a TB treatment. So after 2 weeks of TB treatment, you can start ART. But it is different from the patients who are having HIV and TB meningitis, when you have to delay your ART by 4 weeks. But it should be initiated within 8 weeks from diagnosis. So many of us are aware, many of us not, that we have very good pre-exposure prophylaxis for HIV, and which is also endorsed by NACO in the year of 2022. And this pre-exposure prophylaxis regimens, this is the new game in this disease treatment, that young generation, they are very much aware about this PrEP. They come to their physicians and they request their physicians to start themselves for PrEP. As if someone is on PrEP, the chances of transmission of HIV lowers to many fold. So you have many pre-exposure prophylaxis regimens, but what we follow, that tenofovir and emtricitabine, this combination, 2-drug regimen, this works good as when used as PrEP. And one thing should be kept in mind, that before starting PrEP, the individual should be HIV negative. You have to have a HIV negative test. There should not be any contraindication for these drugs. That individual should be at substantial risk to acquire HIV. Like, that person should tell the doctor that he has some high risk sexual behavior, which engages in different type of sexual activities, where that person can acquire that infection, or injection drug abusers, whom you can offer this as a very good option to prevent the chain of transmission. So this is the regimens which are stated from the NACO in 2022, that you can use this regimen as PrEP, like tenofovir, TDF, the traditional formulation with emtricitabine, or TDF with lamivudine. So now coming to a new drug which is called bictegravir. So there is a big trial, which is, the name of the trial is Alliance. So see that someone is using dolutegravir, so it is very difficult to introduce a new drug to replace dolutegravir with bictegravir. There are some ethical issues with changing a new drug with a previous one also. So they did a very nice study when a patient is infected with both HIV and hepatitis B. So we call it co-infection. They took some of those patients and they did a double-blinded, multi-center, randomized control trial. So it showed that if you replace dolutegravir with bictegravir, so co-formulated bictegravir, emtricitabine, and tenofovir alafenamide is an effective therapy for adults with HIV-1 and hepatitis B co-infection, starting antiviral therapy. So you can superimpose these study results to the only HIV infected patients also. So in my clinical practice and in other ID physicians, we are very confidently using this drug bictegravir. So it has a small tablet size with high barrier to resistance. It has a favorable tolerability, and limited drug-drug interaction profile. Apart from this, I can say that the main issue with dolutegravir is some pre-diabetics, they can have high HbA1c level. There is weight gain in dolutegravir. So these problems are very less with pictegravir. So thank you everyone. This is a concise update for the recent things which are going on regarding HIV diagnosis and treatment. And thank you for your patience. Thank you.
Yes, sir. We will just check the questions from the doctor's side, participants. So just give me 1 minute.
I can see questions in the chat box.
mm,
Should I start answering from the chat box?
Sir, basically it's a live session and question and answer will be on different desk. So I will have to check that.
So
Hello.
are the participants
Yeah.
are the participants able to talk to me?
Yes, sir.
Okay. So please start.
No, sir. Participant not able to talk to. I have to ask the question on the behalf. The first question is from Dr. Suchitra Das. That
Yes,
is,
I can see the questions.
yeah,
So
PEP recommendation
huh,
as per recent guidelines.
yes. So Sucharita Das has asked me that what is the post-exposure prophylaxis recommendation as per the recent guidelines. So it is very easy nowadays, as the standard treatment regimen is TLD, that is tenofovir, lamivudine, and dolutegravir. For the post-exposure prophylaxis, you can use the same formulation. It should be started within 72 hours, preferably within 72 hours from the exposure, and it will be continued for 28 days. And from Rahul Sharma, what can we do to reduce stigma against people living with HIV? So it can be done from an individualistic approach, or it can be done from from a public health approach. So we, the clinicians, it is our duty that we have to explain in detail about the disease to your patient. And along with that, what I follow, what I believe, that might be that someone might not agree with me. So what I tell my patients, that you do not tell anyone about your illness. So if your brother knows, if your wife knows, it is fine. So it is not very prudent to discuss about illness in the community, in friends and all, as there is stigma is already prevailing in our society. So if you tell people about your suffering and all, so that person might get some consolation from people, but otherwise he or she will definitely suffer in any point of time in their lives. So it is the individualistic approach, how to prevent someone to fall into that stigma. But from the public health point of view, as our government is increasingly uh, promoting heart, that is the antiretroviral therapy, and they are also saying that it is a disease like hypertension and diabetes. So you can just have a pill a day, so it can be controlled.
Yeah. Sir, some questions from our personal chat box. That is from Dr. Sandeep Suri from Hisar. Doctor is asking that there is a patient with suppressed viral load and normal CD4 count. That is called elite controlled group. Yeah, they require continue. They require medicine or Not.
See,
We will have to start the medicine or not with that group.
See, so as per the progression of the disease, so we can categorize patients. Some are rapid progressors. Usually, uh, to have a low CD4 count, it takes 7 to 8 years from the day of infection. But in few patients, we see that the deterioration in terms of the number of CD4 cells, it happens over the year over 1 to 2 years. They're rapid progressors. Some very less number of patients we see that the progression rate is very low. So we call it long-term non-progressors. It may be 10 years, 12 years down the line that CD4 is low normal, the patient is doing fine, no opportunistic infections. And what Sarah asked, that is elite controller. That that person will never have a low CD4 count. CD4 count will be normal. But for all patients, from the transmission point of view, all of them should be put on ART. As his or her immunological system is tolerating the virus, but he or she is able to transmit the virus to others. So in all cases, we should put those patients on ART from the to prevent the chain of transmission.
Yes, sir. So one more question from Dr. Tushar Kalra Panipat. That is, sir, can HIV be curable?
It's a very difficult question to answer. There are already many trials, many experimental approaches that are going on, starting from newer antivirals and ranging up to hematopoietic stem cell transplant. So, interestingly, a few patients who had HIV associated lymphoma, that HIV associated with some very life-threatening cancers. So, there are a few reported cases where HIV patient, some HIV patient who had a very life-threatening situation, lymphoma, that's a very fatal lymphoma, and that person underwent hematopoietic stem cell transplantation, like bone marrow transplantation and full body irradiation. So there are few case reports where the HIV got cured, but when patient searches internet and they come up with ideas that HIV is curable. So you have to be very patient to make them understand that no, you are not candidate for such experimental therapies. But we are hopeful that some therapy might come which can cure this.
Okay, sir. Same, one more question from again Dr. Tushar Kalra. There is some patient who are CCR5 negative. They are safe from HIV infection. They are not getting HIV infection. Is that true or not?
So CCR5, as I showed you in the diagram, that CCR5 is the co-receptor for the HIV virus to enter into the CD4 cells. Yes, partially right. They are mostly immune to this virus. I have a question from Dr. Suresh Babu Rao in my chat box, that how effective bictegravir it is compared to dolutegravir. So there is very few smaller studies, actually, very few studies, head-to-head comparison of these two drugs. So larger studies will they are yet to come out, but yes, it is equally effective to dolutegravir with if you compare to dolutegravir. So yes, it is a good drug. From Dr. Vivek Kumar H. Are there any recent studies available on bictegravir involving Indian patients? No. There is no recent studies, but NACO is very enthusiastic to incorporate this drug into the national program. I hope it will come.
Yes, sir. One more question from Dr. S.R. Sahi regarding if chronic kidney disease patient with creatinine clearance less than 30 and he is on the TEE regimen. So what regimen should we prefer for this patient?
See, tenofovir has two formulation. One is TDF, one is TAF. So TDF is the best one, but it has a problem that you cannot give a deranged renal function. So in those cases, the TDF should be replaced with, which is tenofovir alafenamide.
Pradeep, almost all questions has
Yeah,
been- yeah.
yes, sir.
So it's almost close to 1 hour, sir. So it's time, sir, to say thanks to, first of all, you for your valuable time and all our audience. Right now, almost 200 and above our doctors are there with us. And they have got a very good knowledge. And I hope that such kind of knowledge sharing is one of the best platform which can at least save over time. And we would say thanks to everyone who has connected on time for the particular discussion. And for future also, we are expecting such presentations to be happen for the HIV because this is the therapy which can only be come up only as a knowledge, as a experience sharing, sir. So thank you very much for joining with us. Thanks to all our audience to joining with us. And thanks to entire team Hetero for the support system which they had given to us. Thank you.
Thank you everyone. Thank you for arranging this session.
Yeah.
Okay.
Sir, we can
Have a good